Good morning, everyone. The topic of my today's presentation is pharmacological management of schizophrenia. Outline, we will be going through the various guidelines chosen, assessment, treatment of symptom, treatment of special population, and treatment of side effects. The guidelines chosen are the Schizophrenia Patient Outcome Research Team Code Guidelines, the British Association of Psychopharmacology 2019 Guidelines, World Federation Society of Biological, World Federation of Societies of Biological Psychiatry 2012, 13, and 15 guidelines, clinical practical guidelines of management of schizophrenia, published in Indian Journal of Psychiatry in 2017, National Institute of Health and Care Excellence, NICE guidelines, Maudsley guidelines, and Royal Australian and New Zealand College of Psychiatrists Treating Guidelines 2016. First of all, before starting any antipsychotic, we'll first do the investigations. Investigation we'll do to assess the general medical condition of the patient, to rule out any organicity at the baseline before starting any antipsychotic, and for the monitoring of side effects. Now, to assess the general medical conditions, we'll measure the pulse, blood pressure, temperature, body weight, height, serum electrolyte, renal function test, liver function test, complete hemogram, lipid profile, plasma glucose, and ECG. To rule out organicity, CT and MRI, toxicology test, HIV, VDRL, hepatitis B and hepatitis C, anti-NMDA antibody, anti-voltage gated calcium potassium channel antibody, and anti-GAD antibody test.
For any schizophrenia,
So to rule out organicity, we have by BAP, sir, and by World Federation and by friends.
But this is in context, it's case based, or this is any patient from this episode?
So they say that you have to rule out organicity in any patient, but not specifically. At baseline, before starting the antipsychotics, pulse, blood pressure, temperature, body weight, and waist circumference. Waist circumference is being included only by the World Federation Society guidelines, by the NICE guidelines, and by the RENZEP guidelines. Serum electrolyte, RFT, LFT, complete hemogram, lipid profile, plasma glucose, CPK levels, thyroid function test, and prolactin. Pregnancy test considered in the women of childbearing potential, assessment of any nutritional status, diet, and level of physical activity in the patients, and ophthalmological. ECG is recommended for all the inpatients. In patient with history of cardiac disease, especially ventricular arrhythmias, heart block, bradycardia, or family history of long QTC or sudden death, prior to the trial of high risk, high dose, or acute parenteral antipsychotic medications. In patient in which factors present which predispose to arrhythmias, such as any electrolyte abnormality, taking drugs which prolong QT interval, or predisposed to arrhythmias, and in patient in which there is new onset symptoms suggestive of arrhythmias, such as syncope, in patient already on antipsychotics. Monitoring of side effects. So the monitoring of side effects, as per the this RENZEP guidelines, weight should be monitored at baseline, 4 weeks, 8 weeks, 12 weeks, and annually. But NICE guidelines say that weight should be measured weekly for the first 6 weeks, and then 12 weeks, and then at 12 weeks, that is 3 months, and then at 1 year, and then annually. Waist circumference should be measured at baseline and annually. Waist circumference, ECG, and EEG. These three should be measured at baseline and then annually. Blood pressure should be measured baseline at 2 weeks, at 12 weeks, and annually. Fasting blood sugar at baseline, at 12 weeks, and then annually. Blood count should also be done at baseline while admitting the patient at 12 weeks, that is 3 months, and then yearly. Treatment of symptoms. Treatment of symptoms will study while first of all the treatment of prodrome, treatment of first episode psychosis, treatment of acute exacerbation, and treatment of stability. Treatment of prodrome. As per DSM-5, attenuated psychosis syndrome, it is at least one of the following symptoms should be present in attenuated form with intact reality testing and is of sufficient severity or frequency to warrant clinical attention. That is, delusion, hallucination, and disorganized speech should be present in attenuated form with intact reality testing and is sufficient in severity or frequency to warrant clinical attention. Symptoms must be present for at least 1 week in past month, and symptom must begin or must have begun or worsened in the past year. Symptom is sufficiently distressing and disabling to the individual to warrant clinical attention, and symptom is not better explained by any other mental disorder, and criteria for any psychotic disorder has not been met. Now, the treatment for prodrome: frequent review, watchful waiting, and monitoring of symptoms. Cognitive behavior therapy is the preferred intervention. Antipsychotics should not be routinely advised except for the harm to self or other, or if the CBT is distressing. If antipsychotic medication is considered off-label prescribing, short-term individual trial should be given. So very low dose antipsychotics should be given. Symptoms and side effects should be carefully monitored. Omega-3 polyunsaturated fatty acid has shown efficacy in one study, and assess for any substance use in food. So first episode psychosis. The general principle for prescribing is patient and caregiver should be involved in the choice of antipsychotics. Start low and go slow. Avoid combinations of antipsychotic, that is, use monotherapy. Monitor regularly for side effects, and response should be assessed using ratings. Now, choosing antipsychotic for the first episode. There is no difference between first generation and second generation antipsychotics in terms of acute symptom change or time to discontinuation. However, differences in the side effect profile has been noted. A second generation antipsychotic should be preferred over first generation because of better tolerability and adverse effect. And a liberal dose of benzodiazepine for anxiety, insomnia, and hostility should be used. While most of the guidelines do not recommend clozapine for the first episode psychosis, Maudsley guidelines recommend early use of clozapine for better outcomes. Similarly, the use of long-acting injectables in the first episode psychosis is controversial, but British Association of Psychopharmacology and RENZEP guidelines, Maudsley guidelines, recommend it as it improves the compliance, so reduce the duration of untreated psychosis and thus ensuring better prognosis. Now, the minimum effective dose. The minimum effective dose for the first episode, haloperidol, is 2 mg, and multi-episode is 4 mg. And for trifluprezin, it is first episode is 10 mg and multi-episode is 15. And for second generation antipsychotics, the minimum effective dose for first episode amisulpride is 300 mg, multi-episode 400 mg. Aripiprazole 10 mg, multi-episode is again 10 mg. Paliperidone first episode is 3 mg and multi-episode is 3 mg. Cariprazine 1.5 and 1.5. Lurasidone is again 40 mg and multi-episode is 40 mg. Olanzapine first episode 5 mg and multi-episode 7.5 mg. Quetiapine 150 mg and 300. How long to continue? Most of the guidelines recommend continuing the medicines for 1 to 2 years. However, RENZEP guidelines recommend it to continue for 2 to 5 years. If incomplete remission, consider long-term treatment. Long-term treatment generally needed to prevent relapse. For acute exacerbations, for acute agitation, rapid tranquilization is advised. The aim of rapid tranquilization is to calm the patient, not to oversedate. The first step is to offer oral treatment like olanzapine 10 mg or risperidone 1 to 2 mg or haloperidol 5 mg plus promethazine 25 mg. Repeat after 40 to 45 minutes. If no effect is seen, then consider IM injectables, IM lorazepam 2 mg, promethazine 50 mg and haloperidol 5 mg. Repeat after 30 minutes. If no effect is seen, then go to IV diazepam 10 mg. Repeat after 5 to 10 minutes if insufficient effect is seen. For acute exacerbation, the general principle is a poor adherence with treatment plans, side effect including obesity and metabolic syndrome, depression, substance use, complications of polypharmacy, and quality of social environment should be considered and addressed. The choice of antipsychotic should be on individual preference, prior treatment response, side effect experience of the patient, any relevant medical history, and suitability of long-term continuation. Avoid using combination of antipsychotics in acute exacerbations. The efficacy of second generation and first generation antipsychotic is the same, only difference is in the side effect profile and time to discontinuation, because of which second generation are preferred. Dose higher as compared to first episode psychosis and maintenance phase are given. Before considering clozapine, adherence to prior therapy using depot long-acting or plasma drug monitoring should be done. Apparent drug resistance may simply be the result of inadequate treatment compliance. Now, for stable phase of schizophrenia, in general principle, antipsychotic drug which led to the best response and which had the best individual side effect profile during the acute phase should be chosen. Antipsychotic medication regimen should be kept as simple as possible with respect to both number of tablets to be taken and the number of time each tablet taken in a day. Switching antipsychotic medications to enhance therapeutic response, a gradual cross tapering of the doses should be considered rather than an abrupt switch. Intermittent targeted treatment approach should not be routinely used. Now, choosing antipsychotic for a stable phase, maintenance dose is the dose that was effective for the acute phase. Second generation antipsychotics are again preferred with regard to the treatment discontinuation and thus relapse prevention. Long-acting injectable provide best protection against relapse. If the dose has to be reduced after there is improvement in the positive symptoms, it should be reduced at the rate of 20% every 6 months till minimal effective dose. How long to continue? If there are more than 2 episodes in the last 5 years, indefinite and offer maintenance treatment for a minimum of 2 years. Those with history of aggressive behavior, serious suicidal attempts, and those with residual psychotic symptom should be considered. The treatment should be considered for life. Now, long-acting injectables. They are chosen over the oral maintenance. They are chosen over oral for maintenance when this is preferred by the patient. Previous non-adherence has led to frequent relapses, or the avoidance of non-adherence is a clinical priority. For most antipsychotic agent, an initial oral test dose is required before starting long-acting injectable preparation. So the various long-acting preparations that we have are second generation and first generation. For the second generation, we have risperidone microspheres, paliperidone, and olanzapine. For olanzapine, the dose interval is 2 to 4 weeks. The first dose is either 200. If it is given for 210 milligram, it should be repeated in 2 weeks, and if it is given for 405 milligrams, it should be repeated in 4 weeks. For paliperidone, the dose interval is 4 weeks. The first dose for paliperidone, the loading dose is to be given. First 150 milligrams is given on day 1, then followed by 100 milligram on day 8, and that should be applied on the same muscle, and then 25 to 150 milligram every 4 weeks. With olanzapine depot, post-injection delirium sedation syndrome can occur in about 1% of the recipients, so appropriate monitoring for 3 hours post-injection is required. Treatment-resistant schizophrenia. When failed 2 or more antipsychotic trials, exclude any out of the 2 antipsychotic, one should be preferably non-clozapine, second generation antipsychotic, or olanzapine. Exclude any suboptimal dose, poor medication adherence, or substance use. Review diagnosis. Exclude any neurobiological factor, environmental and pharmacological factors. Clozapine is the first line of in the treatment resistant schizophrenia. It is also preferred in chronic suicidal ideation, behavior, hostility, aggression, and if patient's own choice. Augmentation. Around 30% of the patient of treatment-resistant schizophrenia treated with clozapine do not respond. For them, augmentation is required. For augmentation, first you have to make sure that there is adequate trial of clozapine, that is for 3 months. The plasma level of clozapine is more than 350 nanograms per ml. And the plasma level monitoring should be considered when there is concern around clinical effectiveness, emergent adverse effect, adherence problem, or there is interaction with any medicines or changes in the smoking status. Because smoking is an enzyme inducer, so it can change the level of closure. CBC should be done weekly for the first 18 weeks and then 4 weeks. Clozapine augmentation. Augmentation, there is modest efficacy with amisulpride, risperidone, aripiprazole, and antidepressant and a mood stabilizer, lamivudine. However, use of other medications such as augmentation with lithium, valproate, carbamazepine has not shown any robust evidence. Consider ECT, and if adjunct is not effective, taper it off. Now, the negative symptoms and cognitive symptoms of schizophrenia. So, schizophrenia can have primary negative symptoms and secondary negative symptoms. Primary negative symptoms are mainly, which are core symptoms of schizophrenia, like anhedonia, apathy. And secondary symptoms are as a consequences of positive symptoms. Example, social withdrawal because of some paranoid ideas, depressive symptoms because of treatment with antipsychotics, or because of some environmental factors, like social understimulation due to hospitalization. So in the negative symptoms and cognitive symptom, the hypothesis is that there is hypodopaminergic functioning in the prefrontal cortex and nucleus accumbens. So the main receptors for these negative symptoms are D3 receptors. D3 receptors are autoreceptors that are present in the midbrain limbic area. D3 receptors are present in midbrain limbic area. So D3 receptor antagonism lead to increase in neurotransmission in the prefrontal cortex, thus reversing the hypodopaminergic functioning. This is a mechanism of action for behind the effectiveness of second generation antipsychotic amisulpride and cariprazine, which are D3 receptor partial agonists. Similarly, there is one more hypothesis which says that there is a glutamate receptor hyposensitivity. So when there is glutamate hypofunction, the GABA interneurons will not be activated. So there will be increased dopamine. There will be increased dopamine surge in the midbrain, which lead to this symptom. So various NMDA receptors agonists NMDA receptor agonists like D-glycine, D-serine, D-cycloserine, they have been tried, but the level of evidence is low for them. A treatment in special populations in pregnancy, breastfeeding, and in elderly. In pregnancy, there is no clear evidence that any antipsychotic is more teratogenic. Quetiapine has relative low rate of placental passage. Women with established schizophrenia should continue the treatment that is currently keeping them well. Depot long-acting antipsychotics should be avoided for the first time in pregnancy because of the lack of flexibility of the dose. Change in the metabolism of the mother during pregnancy and lactation. There is change in the metabolism in the mother during pregnancy and lactation, so keep a check on side effects. Women on clozapine and olanzapine should be monitored for gestational diabetes mellitus, and start folic acid 5 milligram prophylaxis for neural tube NTD in women on treatment planning for pregnancy. In neonates, check neutrophil count if antenatal exposure to clozapine is present, and check for EPS if antenatal exposure to first generation antipsychotics was present. In breastfeeding, all psychotropics are excreted in breast milk to a varying degree. Continue regime prescribed during pregnancy, as it may minimize the withdrawal symptoms in the infant and also reduce the chances of relapse. Avoid polypharmacy and use lowest effective dose possible. Drugs with short half-lives are preferred, and the women should be advised not to breastfeed if on clozapine. Now, what is RID? RID is infant weight adjusted dose expressed in proportion of maternal weight adjusted dose. This is relative infant dose. So relative infant dose is infant weight adjusted dose expressed in proportion to the maternal weight adjusted dose. So drug with RID less than 10% are relatively safe in breastfeeding. So the RID for amisulpride is 4.7 to 10.7%, which is relatively high. For aripiprazole is 0.9 to 8.3%. For risperidone is 2.8 to 9.1%. For clozapine, it is just 1.4%, but because of the serious side effects of clozapine on blood, it is not recommended in breastfeeding. For olanzapine, it is 1 to 1.6%. Quetiapine, it is very less, 0.09 to 1%. And for ziprasidone, it is 0.07 to 1. When initiating antipsychotic postpartum for the first time, olanzapine or quetiapine is preferred. In elderlies are more sensitive to the adverse effect of psychotropic. It is seen that the incidence of tardive dyskinesia in people treated with antipsychotic medication has been found to be 60% in people aged over 65 years and as high as 93% in people aged over 70. So those may be reduced to half in the management of late onset schizophrenia and as much as 10 times lower in the management of very late onset. The treatment of side effects for EPS, QT prolongation, dyslipidemia, weight gain, and hyperprolactinemia. A general principle is a careful assessment of the risk factors and optimally choosing the antipsychotics. If symptoms are well controlled, then reduce the dose of antipsychotic. Change to antipsychotic with less propensity for a particular side effect and add on agent to treat the side effect. For dystonia, IV, IM anticholinergic drugs are preferred. For pseudo-Parkinsonism, reduce the dose of antipsychotic, change to a second-generation antipsychotic, and prescribe oral anticholinergic and review every 3 months as most of the patients do not require long-term antipsychotics. For akathisia, reduce the antipsychotic dose. Switch to olanzapine or quetiapine. Then add propranolol 30 to 80 milligram per day. Consider low-dose 5-HT2 antagonists like mirtazapine, niansarine, or cyclopentadine. Consider low-dose benzodiazepines like clonazepam or vitamin B6 also might. For tardive dyskinesias, switch to clozapine. VMAT2 inhibitors like tetrabenazine, valbenazine, butrabinazine, and pyridoxine, vitamin E, amantadine, and ginkgo biloba has also proven to show effect. In neuroleptic Meillagen syndrome, in psychiatric setting, withdraw antipsychotic, monitor for temperature, pulse, BP, and consider benzodiazepines, IM lorazepam. Stop any antipsychotics, ICU referral. In medical emergency setting, rehydration, bromocriptine, dentroline, sedation with benzodiazepines, artificial ventilation, and if required, L-DOPA are among the other drugs that can be used. At least 2 weeks should be allowed to elapse after the recovery from NMS before rechallenge, and ECT for the treatment of psychotics. Now, QT prolongation. So if the QTC is less than 440 in men and less than 470 in women, and action, no action is required. If it is more than 440 in men and more than 470 in women, and along with that, consider reducing the dose or switching to drug of lower effect, and repeat ECG. Okay. If the QTC is more than 500, then repeat ECG, stop suspected positive agent. And if there is abnormal T-wave morphology, review treatment, consider reducing dose or switching to the drug with lower. The metabolic adverse effects. The metabolic adverse effects, metabolic syndrome is indicated by the presence of 3 or more of the following cardiometabolic risk factors, like either centripetal obesity, hypertension, raised fasting plasma glucose, and dyslipidemia. Dyslipidemia is either low HDL cholesterol or raised triglycerides. For dyslipidemia, monitoring is needed in clozapine and olanzapine, fasting lipids at baseline, then every 3 weeks, every 3 months for a year, and then annually. And for all other antipsychotic at baseline 3 months and then annually. Basic lifestyle and diet modification should be prescribed. Aripiprazole, drug of choice in antipsychotic induced dyslipidemias, and statins can be used if lifestyle interventions are insufficient. For weight gain, calorie restriction, diet and exercise program, self-monitoring is recommended. Metformin 500 milligram VD can be considered as an adjunct to attenuate or reduce weight gain following antipsychotic medication. Combination of topiramate with olanzapine is beneficial, but agitation or aggressive behavior associated with topiramate therapy has been documented. Other drugs that can be used are amantadine, bupropion, ranitidine, melatonin, orlistat, reboxetine, and zonisamide, but the level of evidence is low for diabetes mellitus and impaired glucose tolerance. monitoring baseline oral glucose tolerant test or fasting plasma glucose HbA1c. And if the patient is on clozapine or olanzapine, the monitoring should be done after 1 month and then every 4 to 6 years for every 4 to 6 months. For other antipsychotic at 4 to 6 months and then at 1. Switching to aripiprazole, ziprasidone, and lurasidone is recommended. Clinician must balance the possible benefit of switching antipsychotic medication against the risk of inducing relapse of core psychotic. Hyperprolactinemia. So what is the level of range of hyperprolactinemia? In women, the normal range in nanogram per ml is 0 to 25, and in milli international unit, it is 0 to 530. In men, it is 0 to 20 is normal, and when it is 25 to 118 nanogram per ml or 530 to 2500 milli international unit per liter, it needs assessment. And if it is more than 118 nanogram per ml or more than 2500 milli international units per liter, it needs RIF. If asymptomatic, no treatment is required. If symptomatic, switch to a non-prolactin elevating drug. Alternatives can be to add aripiprazole to the existing treatment. Those who cannot tolerate above amantadine, cabergoline, bromkriptine can be used. Worsening of psychotic symptoms should be monitored.
Basically, the beginning, you mentioned the maintenance and acute that's eight.
It was an alien that I removed. This presentation was 70.
This was taken as a template.
This was taken as a so there was a enhanced presentation.
Or acknowledging the definitely you can access. Did you check?
I did. So that was an old presentation, so I just trying to update that.
Patient is based.
Yes. In Renzi also it is and
I would propose which all right to start
it is written the British Association Secretary for Guidance.
Definitely, thyroid involvement can be there. Specifically starting antipsychotic, what is it? We are doing as a baseline, is fine, but specifically for starting in the antipsychotic. Antipsychotics will have some role play with it, or maybe they will also play later on. So that I would actually be more in psychotic. Maybe when you say that collective inhibition, I could find more in paradigm about the rule of because this is actually very complex. It's like in the next example of the why ECT, why you want to do this. All these things are used to the previous line. Why are these based? Everything the writing is so even LFTs, even function. So this is
If there is any QT correlation with respect to age, then we can stop. Can start with a low dose.
started. So you will be more cautious. If there is some amount of cookie vision at the baseline of it, remain the same, after giving antipsychotic. But if at the baseline it is normal, then has increased. Although when you are guidelines to reference that like seen reference for this. In that patient will be cautious because it has been distributed like a period long probably. That is why it's actually even also the parental life British will not start parental life who they have in the city. Very here we at times do very much sure. State of different monitoring 3 months. 3 months. Other antipsychotics, it becomes baseline and replacing it is different. Generally, 6 months. The deviation criteria is deviation spectrum.
That should not in the Indian scientific. It was written at the level of evidences.
Most of them utilize that. Those mostly that is why it is But off-label use is not, that is not approved, but still you can use it. Yes. Further infections and you have the safety. RIDs are not equal. And the dose taken by the mother, and presumably the dose taken by the roughly calculated that in that scene. That is not a good way. No way you can accurately assess the drug levels till you actually measure it in the blood and in the not equally. Which increase the risk of
So we very so in one injection will be dead. And after 15 days, you can stop using it and start 15 days. However, if injection, you give injections of 200 and 20 milligrams per hour. Then after 1 month, then we stop the medication and then we start just the 400 milligrams of injection.
think we will be able to use it when it is available. Other depot antipsychotics which can be used without priming it with prior antipsychotics, paliperidone and also
So RANSEP guidelines, they are also like 2017 guidelines. They also do not recommend the use of olanzapine as a first-line drug in first episode psychosis. They prefer first to try with amisulpride, paliperidone, lorazepam, and then if no response is seen, then olanzapine, and then if no response is seen, then
any guidelines or any commitment about clozapine resistance? Clozapine resistance to the product.
In every guideline it is mentioned about the augmentation of clozapine resistance or augmentation.
Resistance to the question is specific. Then some schizophrenia will not respond to it. What are the pharmacological? These specific augmentation strategies are all
So augmentation of amisulpride, few antipsychotics they have.
So World Federation of Social Biology and Psychiatry says you can still do a trial of other guidelines. You have to say something else. You can always add it up in this. Refer to various guidelines. But I think very important message with the presentation gives is the no antipsychotic differs from each other as far as the efficacy is concerned. Only the difference is in the side effect profile. So, except so this is a very important difference. So when you start to say the exams, any case, so what antipsychotic you will give, then you have to actually see a side effect profile, patient's profile, and then comment on the group of that. Don't say olanzapine. I was just judging a TISA this week. So there's a case they said olanzapine. Everyone was saying why not any other? Why only? So if you are particularly naming a drug, then you have to say why you choosing that. Otherwise, tell a group. Let examiner ask you any specifically antipsychotic you want to choose from that group. Otherwise, you have to be as generic in your answers as possible until unless asked. Dr. Brown is launched maybe. What is your question? It would be available in class, pharma industries. But you can't answer that in your exam. Which is not available. You're not using, or it's not available. It's difficult to. What about polypharmacy?
In any of the guidelines, it is not.
And regarding neuroimaging, I think you should go and cross check and see, except Texas guide, no other guidelines would recommend mandatory neuroimaging for patients with schizophrenia before starting treatment. So they say clinically have this patient. If clinically you feel, then you do an analysis. But it is not mandatory, except Texas. That is what I read. If there is an count, you gave a reference of 3 guidelines. Please check it again. If the thing, if that is so, please also come back and what are the okay. And it's on Jelly withdrawn, caliper wrong, blue, used, it's a famous company has withdrawn, the local company. So it's still available, not available in the market. So if you're seeing this, right, left, and side. This could constant. I think you've seen this was done. Randomly shape that. I think the your presentation is very related, but I agree with that. When you any resource use solution, secret, we should be ready with the question. Very, I think, good presentation. Whatever sources are connected, very enriching presentation. Every slide had huge amounts of information from there. So I think you need to represent it again, or we need to go through the video recording again to concretize all the data. So it's a very important presentation. Not even, I think one slide was casually put up, and a very difficult presentation. Schizophrenia, pharmacology, are the hot buttons in psychiatry. So whatever platform it is presented, it is actually one of the highest attended programs in most of the cities. So in that sense, it is actually a very good effort, and this will benefit you from now on when you start to approach your patients. It will actually benefit. So you need to be lucky to have these topics as a presentation. Then you thoroughly read it, and then subsequently you follow